Well, thank you for coming to my head talk on palliative care because patients are worth it. And I want to take you on a journey of my career and how I came to realize that a palliative approach to patients really was worthwhile and important for the practice of neurology. I started my practice as a movement disorders clinical trialist and involved in the deep brain stimulation program. So I was as interventionist as a person could be when one is dealing with neurodegenerative disease. Thinking about suffering, thinking about end-of-life issues wasn't relevant to me because people don't die of Parkinson's, do they? They die with Parkinson's. That's what I was taught. That's what I told my patients. Well, that's wrong. Because of the top 15 causes of death in the United States, 3 of them are neurologic. And indeed, I would contend that most of the people that are contained in those deaths from pneumonia really are hiding many of our patients with neurodegenerative disease for whom aspiration pneumonia is the commonest cause of death. And so it's not just movement disorder neurologists who have to be concerned about suffering and end of life. It is really this entire group. And why is this important? Because there is a gray tsunami approaching us. And that gray tsunami means that the population is getting older and older and older. And as they are getting older, they have more comorbidities. They have more complexities. And so using a palliative approach earlier in the course of the illness may be appropriate because we can address suffering. And when you look at the 3 top causes of death due to a neurologic disease, you see that dementia, stroke, and Parkinson's disease all increase in prevalence according to your age. So the older you are, the more likely you are to develop these illnesses. And why is that important? Because the traditional palliative model involves patients who are going to suddenly die. They have a predictable course of death. If you think about people who die of cancer, they die in weeks or months or maybe at the most years. Whereas our patients live with their illnesses, they're suffering for decades, their caregivers and spouses are really accommodating to their illness gradually over time, and they have an unpredictable course. So they decline and they might bounce back, but they continue to have this downward trajectory, and we can't really predict when they will die. So as opposed to the hospice criteria that requires us to give that Midas muffler guarantee that our patient is going to die in 6 months, our patients with neurodegenerative disease have an unpredictable course. And the other issue is that our patients have the impression that when they come to an acute care hospital, that they are going to survive. And why is that? They couldn't have gotten this idea out of the blue. Well, there was a very neat paper back in 1996, and they actually got money to watch television. And what they did when they looked at all the episodes of Chicago Hope, ER, and Rescue 911 from the 94 to 95 season, they found that there were 60 occurrences of out-of-hospital cardiac CPR, 75% survived cardiac arrest. That's amazing. Like, that's incredible statistics. And at least 68% survived to discharge. And we all know that the actual survival from out-of-hospital cardiac arrest is significantly less than that, at the very most 20%, and that's mostly among young, healthy individuals. So our patients are not only declining, the numbers of these patients is burgeoning, and there's a palliative care workforce that is not accustomed to our patients. They typically use drugs that are disastrous for our patients, like Haldol. There is also the economic costs of this. And this is a rule from Alberta, because we're in Canada today. So this is from Alberta. So there's the 65-5 rule of healthcare costs, that 65% of healthcare costs in Alberta are spent on 5% of the population, and that 15% of the highest cost individuals are at the end of life. And you can see here from these statistics that you're more likely to be in that top 5% the older you are. What this means is that many of our patients are receiving expensive but also burdensome treatments without the hope of gaining function and returning home to the kind of quality of life they want. And so I hope, just through this brief snapshot, that you will see that there is a reason to change the palliative care and hospice movement from end of life, that is the way it started, through to being applicable throughout a disease trajectory, that we should move from being cancer focused, and indeed most of palliative care in North America actually sits under oncology. And this is different from other places in the world where palliative care is a standalone specialty. And we should move to chronic illness, because really people dying of chronic illness is going to be the big bellwether for our healthcare system. That we need to move from silos where we're the neurologists looking after the acute issues of patients, and we should move to where palliative and supportive care is really everyone's responsibility. We should be able to incorporate these principles of holistic care, of changing our unit of care from the patient alone to the patient and the caregiver and their family. And so some simple things for you to take back to your practice is to be a little more mindful about eliciting patient values and goals. You know, I was brought up that you give a diagnosis and you give a prescription. Sometimes you do some tests. Then we moved to full disclosure, which in many people's minds means that you're going to give a data dump. You're going to give lots of data to the patient because you want them to be fully informed. But really what we need to get from our patients are their goals. What is important for them? What are the moments in their lives that were most meaningful? And that will help us guide their treatment. That will help us understand what is important to them. And that's what they want. They want to be seen. They want to be heard. To acknowledge their losses. I think people feel that this is, kind of depressing to acknowledge their losses, but I think it's important to say, you've lost a lot. You used to be a litigator, and now you can't find the words to put forward an argument. You used to be able to drive long haul, and you loved being on the prairies. You can't do that anymore. We need to acknowledge these losses, but we also need to emphasize what is working. So sometimes patients say, I'm useless. I can't do anything. And yet there are still moments of joy in their life, and we need to emphasize that. We need to help them focus on what is working and what can be done and give them hope. And especially, we need to acknowledge the caregivers of our patients and support them, because they're the people who are going to keep our patients going. They're the people who have a lot of expertise about our patients, and we need to support them in this journey. And I think if you incorporate just those 4 steps, that you will find your practice is much more fulfilling, as it has made my practice more fulfilling. And of course, the most important reason why we should incorporate these 4 steps is because our patients are worth it. Thank you.